Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying about the Bullous disorder. It's quite a long topic. So let's study. Remember this figure about the Bullous disorder. Whenever the question of Bullous disorder comes, this should be the first thing that should come to your mind. So Bullous disorders are disorders characterized by a group of skin diseases, that is basically the blisters. So I have told you B for B, Bullous is for blisters, that you need to remember, right? They are due to the loss of adhesion between the epidermal cells and of epidermis and dermis, right? This is your dermis, this is your epidermis. So the adhesion between them is lost. Adhesion. Adhesion between them is lost, okay? Let's just review the structure of the skin that we have seen. In the epidermis, you are having the stratum basal, spinosum, granulosum, and the corneum. The mnemonic was come, let's get sun, fun. In the desmosomes, there is cell-to-cell adhesions that is there of Desmoglein 1 and 3. In the hemidesmomes, there is cell-to basement membrane adhesions that you are able to see. What is the classification of Bullous disorders? This are the classification: Pemphigus Vulgaris, foliaceous, then paraneoplastic pemphigus, IgA-pemphigus, Bullous pemphigoid, and cicatricial one, right? In the genetic one, there is Kindler syndrome, infectious, Bullous empedicus is there. It is mainly found in the children's, right? Drug-induced one will be there, drug-induced pemphigus will be there, and in the miscellaneous, you have the porphyria cutaneous. So, if I talk about the Pemphigus vulgaris, this figure should come to your mind. What is the pathogenesis? There is autoantibodies against the Desmoglein 3 and Desmoglein 1. It involves the type II hypersensitivity reaction and it leads to Acantholysis, that is loss of cohesion between the keratinocytes, loss of cohesion between both the cells. Histopathology, there is suprabasal split, okay, like if this is the layer now, let's say this is the layer, so there is basically, and this is the super layer, there is what? Suprabasal split that we are able to appreciate, and there is something called as a row of tomb appearance. In the direct immunofluorescence, you are able to appreciate a fishnet pattern. See, how does a fishnet look like? This is a net. I know I'm not good at drawing, just assume that this is a net. Fishnet. There is a fishnet pattern, okay? Actually not like this, it is very bad diagram that I have drawn. I'm drawing it nicely. Wait. Something like this. You know now what is fishnet, right? Then if I talk about the clinical features, then the age is mainly 40 to 60 years and there is mucosal involvement. There is flaccid bulla that ruptures easily due to the erosions. Nikolsky sign is positive. Nikolsky sign occurs when like hand. There is a blister. If I just rub that blisters, then what will happen? The rubbing will cause the blister damage. Okay, that is nothing but the Nikolsky sign. How will you make the diagnosis? Diagnosis via the Zank smear. You are able to see the acantholytic cells. For the treatment, you will give the systemic corticosteroids and immunosuppressants. In the biological, you will give the rituximab. In the Pemphigus Vulgaris, what you need to remember that you have the autoantibodies against Desmoglein 1. And in the clinical features, you have there is no mucosal involvement that is there, and there is fishnet pattern that you will be able to appreciate. In the Pemphigus erythematosus, what you need to remember, there is overlap between the Pemphigus foliaceus and lupus erythematosus, and there is ANA positive. In the direct immunofluorescence, you are able to see there is intracellular IgG and granular deposits of the basement membrane. In the paraneoplastic pemphigus, It is mainly associated with malignancies like the Hodgkin lymphomas. Autoantibodies are also there, and severe mucosal erosions will be there. In the pemphigoids group, you have the first one, that is your bullous pemphigoid. That is your bullous pemphigoid. So you have the autoantibodies against the BP180. Then they spread in the laminal lucida, which further leads to the type II hypersensitivity. And mainly it is found in elderly who are more than 60 years of age. Hence, bullae is there that does not rupture easily. Nikolsky sign is negative. In the histopathology, there will be supradermal blisters with eosinophils. In the direct immunofluorescence, you are able to appreciate that there is linear deposits of IgG and C3 along the basement membrane. Okay. For the treatment, you will give the tetracycline and nicotinamides. Okay. In the cicatricial pemphigoids, there is chronic scarring will be there. Risk is it has a risk of blindness. In the direct immunofluorescence, you will be able to appreciate a linear pattern of IgG that will be there. For the treatment, you have to give the dapsone. In the pemphigoid gestationitis, it is mainly related to the pregnancy. So gestation basically is related to your pregnancy. Okay. The autoantibodies are against BP180. For the treatment, you have to give the systemic steroids because they are safe in pregnancy, and we have already discussed that you have to avoid the teratogenic drugs because they can cause harm to the fetus as well. Next you have is the dermatitis herpetiformis. So it is an autoimmune disease mainly associated with gluten sensitivity, like your celiac disease. And in celiac disease, what are the triggers that you have to tell me, right? So patients who are gluten sensitive are mainly likely to develop this kind of disease. It is IgA antibodies are there, autoantibodies are there, and there is supraepidermal blisters with neutrophil microabscesses in the dermal papilla. In the clinical features, they are extremely pruritic. You have the group of vesicles on the extensor surface like your elbows, like your knees, and like the buttocks. Okay. It is mainly associated with HLA, BA, DR3, and DQ. In the direct immunofluorescence, you are able to appreciate a granular IgA deposits at the dermal papilla. For the treatment, you have to just ask the patient, don't take the gluten, just avoid the gluten-rich diet. You have to take a gluten-free diet. In the drug-induced Bullous disorders, it is mainly impacted by the drugs. So you have penicillin, furosemide, and captopril. What is the mechanism? There is autoantibody inductions or direct cytotoxic reactions that can be there. Management will be to withdraw the offending drug. Whichever the drug that is affecting the person, just try to avoid that person, and you are able to see that there is reversible changes that the person body will have. If you withdraw the drug, then it's likely that the person will not face the same disease twice or thrice, right? In the bullous impetigo, see this child, he is having ulcers around his mouth, right? So in the bullous impetigo, it is caused by the Staph aureus superficial flaccid bullae in infants or children. So toxin targets the Desmoglein 1. For the treatment, you can give the topical mupirocin and the oral antibiotics, right? Then you have the stiff SSSS. What is that? Staphylococcus scald skin syndrome. It is due to the exfoliative toxin spread. Widespread erythema will be there, bulla will be there, and exfoliation will be there. Nikolsky is positive, but there is no mucosal involvement. Mucosal involvement is not seen. This is basically our very beautiful summary table. Let's see that. In the summary table, fishnet pattern is seen in the Pemphigus vulgaris. Most common subepidermal autoimmune blister is seen in the bullous pemphigoid. Gluten sensitive, you have to remember dermatitis herpetiformis. Antigen in BP bullous pemphigoids is BP180 and BP230. In linear IgA depositions, there is linear IgA dermatitis. Okay, Nikolsky positive in PV, Pemphigus vulgaris, and your SSS syndromes. Oral first sign is present in Pemphigus vulgaris. Let's solve this question. Most common autoimmune bullous disorder is it Pemphigus vulgaris? Is it Pemphigus foliaceus, bullous pemphigus, or the dermatitis herpetiformis? So the answer to this is, will you tell me the answer? Just tell me the answer, okay? This is your homework, okay? This you have to find out and tell me what is the answer to this. I'm not telling you, because whenever we solve question, I just read the question and just tell you the answer. So you are not doing anything. So just make sure you have to search this question and give me the answer. So if you are having any sort of doubt, please feel free to ask me. Please feel free to DM me. Thank you so much.